Hello, I'm Iryna Sabat. I'm the ETN Fellow based in Lisbon, Portugal, and I would like to present you the results of our research entitled Hospital Financial Performance and Quality of Care Evidence from Portugal. This is a joint work with my supervisor, Pedro Pitabaros. As you know, Portugal was severely hit by the economic crisis of 2008, which led to the adoption of severe austerity measures that implied significant hospital budget cuts and led to high indebtedness of public hospitals. So we posed two research questions here. And the first one was whether financial pressure at public hospitals influenced quality of inpatient care. And the second question was related more specifically to the Troika regulation period, to the austerity regulation. And we wanted to know what was the effect of the Troika regulation on the adjustment of hospital care quality to changed financial conditions at Portuguese hospitals. To address these questions, we used the following empirical model, which is based on the partial adjustment mechanism. On the left-hand side, as a dependent variable, we had quality of care indicator for a specific hospital in a specific region for a specific quarter of the year. And then on the right-hand side, we had a number of regressors. So first, we included the lagged quality indicator, then lagged financial indicator, because changes in finances may need some time to impact the changes in quality. And then we included a set of hospital characteristics such as teaching status, VLS status, the capacity of the hospital, the number of surgical operations performed at the hospital. We also looked at mean age, share of female, share of patients admitted to the NHS, share of emergency admissions, share of ambulatory treated patients, mean case mix index, and mean length of stay. And additionally, we also accounted for area income, and we measured it using annual regional per capita GDP in the area where the hospital is located. And finally, we included a set of fixed effects, in particular, those that represent hospital quota and year fixed effects. And we conducted the estimation using fixed effects. Now let me briefly introduce you the indicators we used. So for the quality side, we used 30-day in-hospital mortality rate with respect to a number of diagnoses. So for this, we used the patient level DRG data for the period 2008 to 2017, and we looked at such diagnoses as acute myocardial infarction, stroke, heart failure, pneumonia, hip fractures, and a number of others. Then we also decided to look at the patient safety side, and because this is also a set of indicators that reflects the quality of patient care at the hospital. And here we looked at the rates of adverse patient safety events. We used the same source of the data and addressed such indicators as pressure ulcers, retained surgical item, in hospital falls with hip fractures, and a number of others. And particularly, we also looked at post-operative indicators such as the post-operative hematomas, sepsis, kidney injury, and so on. And we also distinguished between surgical related and nurse-related patient safety indicators. And as for the hospital financial indicators, we used hospital financial reports for the same period and computed operating margin, total margin, EBITDA margin, cash flow to total revenue, and salary to total revenue indicators. And then we divided hospitals into percentiles based on the quarter of the year and let them move in between these hospitals across the study period. So this is where the variation comes from. So moving now to the results, here is the baseline model, which means that we used operating margin as a financial indicator and quality indicators as dependent variables, so mortality. And we found out that only in 2 cases, so in case of acute myocardial infarction and abdominal aneurysm, the result was significant, meaning that hospitals that were financially performing poorly had higher mortality rates, But again, this was true only for 2 indicators out of the whole range that I showed previously. However, when we moved to patient safety indicators and looked there, the picture looked completely different. So we actually saw that in case of almost all patient safety indicators, lower financial performance was associated with higher rates of adverse patient safety events. This looks more disturbing, and based on this, we could draw the following conclusion. So first of all, Portuguese hospitals overall showed resilience to financial difficulties during the post-crisis period, but some indicators pointed out potential concerns, and we mean the patient safety indicators. Hospitals that were in lower financial quartiles may have lower quality of care, and we judge this by the direction of the effect, because many of the values were insignificant, but hospitals in lower financial quartiles may have higher rates of adverse patient safety events. And here we can talk both about the direction and the magnitude of the effect. We also found out that changes in quality of care and patient safety are responsive both to large and small decreases in financial performance. And we also found out that some indicators are responsive, only some indicators are responsive to financial changes. So whether there is no relation indeed, or whether time is the issue, so more time is needed for the quality indicator to show that finances have an impact on it, or whether it's just not sensitive, we don't know that. And finally, as per our second research question, we found out that during the Troika's period, the mortality in hospital, 30-day mortality was lower, while patient safety indicators, so the rates of adverse patient safety events, was higher in hospitals with in the lower profitability quartile. So what are the policy implications of these findings? First of all, financially fragile hospitals need to be carefully monitored. And this is important, especially during such turbulent times as crisis periods. Secondly, enforced cost containment measures, such as were imposed in Portugal, may drive hospitals to cut corners on materials and staff, and this may in turn affect patient safety, especially when it comes to patients that are undergoing surgical interventions. So such initiatives, meaning cost containment measures, should be carefully planned and carefully supervised. Thirdly, we found out that traditionally used mortality indicators for quality of care may not actually reflect the decrease in quality of care because they are not fast enough. They don't show it fast enough. So the policy implication can be that the quality should also be assessed using alternative indicators. And we, based on the results of this research, we suggest that patient safety events can be used as alternatives to show the changes in quality triggered by the changes in financial situation of hospitals. Thank you for your attention.